Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the state of Utah, check in how we're doing, and kind of have a discussion about what's been going on. As always, I want to start with case trends and what's been going on in the last week since we spoke. Our state is at a total of 81,947 cases. Today's rate was just released, or today's case counts were just released at 1,501, which is our single highest case counts of one day that we've had so far. We have a total of 501 deaths, and our hospitalization total is 4,167. Eddie, I want to talk about case counts first and just this high case count of today. Where are we seeing these spikes happen, and what are your concerns with the fact that we just keep going up in numbers?
Yeah, huge concern, right? Not the news we wanted today with, the highest case counts ever recorded in Utah. Clearly, we certainly haven't righted the ship in terms of the epidemic here in Utah. We're definitely seeing changes of the epidemic here in Utah. So a couple of those we should get into. 3 weeks ago, we saw this really high increase in cases in the 15 to 24-year-olds. Now what we're seeing is that case count going down, while the case counts in the 25 to 44-year-old, 45 to 64, and the older folks are actually going up. And so this is exactly what we were worried about, in the fact that the 15 to 24-year-olds are taking those infections home with them and then spreading into mom, dad, grandma, grandpa, and other community members. And that's exactly what we're seeing right now. And the huge concern about that is that 15 to 24-year-olds don't often get hospitalized. Yes, they do, rarely, and we've seen really sick people in that age group. But the 25 and up, particularly those that are above age 50, they're the ones that are going to get hospitalized. And so as we're starting to see those cases go up, those are going to be the people that are going to fill our hospitals, because they're the people with more comorbid illnesses that typically have more severe disease. And so it's a really, I said it before, it was a concerning trend because we knew what was coming. Well, that reality is now, and now what we're seeing is a rise in those older age groups, and we're now seeing hospitalizations go up. And so that's one key change that we've seen in the past 3 weeks, and is really being highlighted now. And the other thing that we're really seeing is that Utah County numbers are going down. Okay, and I'd like to say it's due to the mask mandate. I don't know if anything else has changed. I don't know any numbers in terms of compliance of masks in Utah County. But that being said, when you look at the cases per geography and per county, we are seeing cases go down in Utah County, which is really encouraging. And now we're starting to see the Salt Lake County numbers start to tick up again, and kind of a second wave in Salt Lake County, particularly in the southern part of Salt Lake County. Draper area is having really significant increased cases. So in a nutshell, if you look at all the cases across, the state, we're not headed in a good direction.
I want to talk a little bit about Utah County too. BYU tweeted out something earlier today about their case counts, which I thought was interesting. They're having a lot of their quarantined cases go back to school now. So it seems like they are getting that under control a little bit more, which is great. That 15 to 24-year-old age range you were just talking about seems to be complying more with wearing a mask, which is awesome. I want to just touch on the hospitalization piece a little bit more. We know that our hospitals are seeing an increase of patients. Can you kind of break down who is in our ICUs right now, and also what that means? Because I know we've talked about it before, that it's not the beds, it's the caregivers that are really important, and break down kind of what's happening with our ICUs.
Yeah, so when we look at our hospitalization numbers, we are now at numbers that are higher than where we were in July. Okay, so we saw that spike really kind of hit us late June into July. That followed with a spike in hospitalizations, where we were kind of flirting with that 80% capacity number. And now our hospitalizations across the Intermountain Network is higher than it's ever been. So we're setting now daily records of hospitalizations of COVID-19 patients. And that's really stemming from this increase in the population that are more likely to be hospitalized, those over the age of 50. The challenge that we're having as we're opening up new units, new overflow units to accommodate these COVID-19 patients, is that we still have plenty of other patients in the hospital. We still have trauma patients and surgical patients and heart attack patients. And those people need to get the care that they deserve. But the challenge now is that we're now being inundated by COVID-19 patients. And so we're having to, obviously care for both. And when we're starting to see this trend of increasing hospitalizations, right now we're managing, and I don't want you to think that we're managing as business as usual. There's nothing business as usual about this. We're load leveling. We're sending patients to different hospitals in our network to make sure that all of our hospitals are going to be at capacity, not just Intermountain Medical Center or LDS hospitals, but all of them. And so we've got this balance across this system in terms of beds and caregivers. So this is not usual for us to have to do this right now. But that's what we have to do to really accommodate what's happening. This is a surge. This is a surge of COVID patients that we're having to manage and deal with. And so right now we have the physical beds and we have the caregivers. But I think from a caregiver standpoint, you have to think of two things. One is, are we going to not have enough caregivers, but have enough beds? And so then patients that have severe COVID-19 are be taken care of by physicians, nurses, pharmacists, respiratory therapists that aren't necessarily trained to do so. If I were in the ICU, I want a pulmonary intensive care doc taking care of me. I want a pulmonary intensive care pharmacist and nurse and respiratory therapist. And as this grows, that's not going to be the case. They're going to be overseeing care provided by other people. We haven't gotten to that point, but that's part of our plan in terms of expanding care. And so it's just the physical bodies, but it's also the mental exhaustion that is currently and physical exhaustion that are on our caregivers. And that's something that, can't be understated. I mean, these caregivers have been working with COVID-19 patients, for months now, since really April, May, and people are tired and they're a little disheartened when they see, record case counts today. This isn't ending anytime soon. And it's, just really, really taxing for all of us involved in it. We'll keep going. We'll keep caring for patients. But it's something that, it's kind of a part of our plea to the public of Utah is that help us out, do this for us as well, and our families that are struggling with this. And then another thing to kind of keep in mind, as cases go up, testing goes up. And so we need more caregivers for testing sites, and our testing sites are getting overwhelmed. And so it all snowballs on top of each other.
I was going to bring up the testing sites too. We know that there's been a decently long wait time at some of our testing locations just due to demand. And I think it's important to note that the more we can keep ourselves safe, wearing a mask, staying home when we're sick, or when we don't need to be going out, the less of a strain we're going to be putting on our testing sites. Because like you said, if we're running out of people to give those tests, it creates an issue for us. And obviously, if you're sick and you need to get tested, we want you to get tested. But there needs to be this balance of, am I leaving my house just because I want to, or do I really need to be going out and doing all of this stuff? But what can you speak about in terms of testing? What have we been seeing?
Yeah, I mean, our test volumes have been really high. And so when you look at the state data, which really reflects Intermountain data as well, is that we've had some of our biggest testing days in the past 2 weeks. A couple of days really almost hitting that 10,000 tests per day mark. And what's troubling is that our testing, a percent positive, still is remaining quite high. So we have a percent positive reported today at 13%. Which tells us a couple things. One is there's likely plenty of people out there that are not getting tested that are positive when we have that high of a rate. I don't think it's just the fact that people are being kind of changing who is getting tested, like people only consistent with COVID-19 are getting tested. I think this really reflects the fact that we're likely under testing, and that there's plenty of COVID-19 in our communities that we're not detecting through testing.
And you brought up the fact that there could be other things happening right now. I want to talk a little bit about the flu. Flu season is here. It feels really warm right now in Utah, but before we know it, it will start to get colder and influenza will be starting to make a presence in the community. What advice do you have for people on how they can keep themselves safe and kind of help the healthcare community through the flu season?
Yeah, I mean, two really big things, three. Get vaccinated for influenza. That's easy to do. It's safe. And when I say it's effective in reducing severe influenza. And severe influenza is what ends up in our facilities and in our hospitals. If this trend continues, we're going to need all of those beds for COVID-19 patients. And, if we can do anything to prevent hospitalizations, we need to do that. And one of the big things that we can do as we move into the kind of late fall and early winter is influenza vaccine. So October is a great month to go out and get your flu shot, and just get it done, because it's going to, help us out from reducing in severe flu, which comes into our hospitals. The other things, you may sound like a broken record. It's wear a mask and, limit your social contacts. And the reason that's important outside of COVID is that those things reduces other viral infections, and other viral infections like influenza end up in our hospital. And so all of those kind of public health measures that we talk about for COVID extend to all other respiratory illnesses. And if we can minimize those, we can minimize our testing, which will open up some time and have decreased, wait times for the people that need it. And it'll decrease our hospitalizations. And so it really is all incumbent on those good public health practices, which include vaccination.
You mentioned the importance of wearing a mask. We've gotten a few questions in the past around, if I'm wearing a mask, will I get the flu, or what's the purpose of me getting a flu shot? I'm wearing a mask. Isn't that supposed to protect me? Is there any sort of data behind a mask protection for the influenza specifically? And do you think that if people are wearing a mask, it really will reduce the amount of influenza we'll see?
Absolutely, 100%. I mean, influenza travels on droplet particles, just like SARS-CoV-2, or the virus that causes COVID-19. And so the same exact principles apply. And so if we're minimizing the transmission of SARS-CoV-2 with a mask, we're going to do the same thing with influenza. And it's the same transmission pattern. And so, absolutely, it's going to be beneficial.
You also mentioned the vaccine itself, and I just wanted to let people know that we do have a wide variety of locations that they can go to. We have drive-through clinics happening. We have our pharmacies giving out flu shots, and then you can always get one at your normal scheduled appointment. But there's a website that we have right now. It's intermountainhealthcare.org/flu. If you go onto there, there's a public flu location list that you can go through and find a location nearest you. The hours do vary depending on where you're going, and it'll tell you if it's going to be curbside or if you need to go inside. So it just kind of varies. And one more question for you on the flu. I want to talk about the similarities in symptoms. It's a big thing that even in March, when this was starting, we were seeing the end of flu and the start of COVID. Are there similarities in symptoms between the two? And if so, does this complicate things as we go into the season?
It absolutely complicates things. They're indistinguishable at this point. We don't have the ability, just based on history and a patient's symptoms and physical exam, to be able to distinguish between COVID-19 and influenza. When you think about influenza-like illness, which is kind of the definition you think about when you're concerned for flu, it's fever with a respiratory complaint. That's it. So it could be fever and a cough, fever and shortness of breath. That's COVID-19, right? And so COVID-19 is, a fever, cough, respiratory complaint, pharyngitis, sore throat, runny nose, all of those things. And so the overlap of these two viruses is going to make it really hard to differentiate these. And the reason that's so important is that we have pretty good therapeutics for influenza. Okay, if we have a drug called Tamiflu. And so if somebody comes into an urgent care to the primary care office with symptoms that can be consistent with flu or coronavirus, we need to make sure that we diagnose influenza if they have it, because we want to make sure that they get on appropriate therapies. And we know that patients can have both COVID-19 and influenza at the same time. And so we are setting up testing protocols within our urgent care and EDs and primary care offices to really say, don't forget about influenza. Not everything is COVID-19 as we move into this season of flu, and that we have to be evaluating patients for influenza as well, if it's going to change your management. So if you have a young, healthy person who's had symptoms for 4 or 5 days, that's not somebody you're going to treat with Tamiflu, and you may just test them for SARS-CoV-2. But if somebody comes in early in the course, or they have complicated medical conditions where they would get Tamiflu if they had influenza, we're going to be testing for both. We can't distinguish these just based on clinical, grounds by themselves. And so it's going to be really hard. And we have set up some testing protocols to make sure that we are looking for both flu and COVID-19.
I did not know you could get them at the same time. That does not sound very fun. So that's a good piece of information for people to think about when they're going about their fall season into this winter time. My next topic I want to talk to you about is schools. We've seen a pretty big increase in schools, and we've had various schools go into this 2-week period where they're doing online learning only. And I want to talk about the importance of quarantining while you're waiting for results. We understand waiting for results can sometimes be super stressful, especially if you're a high school student, you want to get back to school, but hanging out with your friends. Why is it so important to quarantine until you get those negative results, though?
Yeah, so think about the reason we quarantine, especially with this virus. We know that so if you're going into quarantine, it means you've had a high risk exposure. And so you've been near somebody for greater than 15 minutes within 6 feet. It's a high risk exposure. So we know that your chance of infection is much higher than the general public in true high risk exposures. And so we know that you may develop symptoms in the coming 14 days. Most commonly, people get symptoms within 5 to 7, but the incubation period can go up to 14 days. And we know that many people will be infectious before they develop symptoms, if they develop symptoms at all. And so, you may start having virus shed in your nose and you're infectious at day 5, but you may not develop symptoms until day 7. And so if you're on a quarantine and you're out seeing your friends because you feel okay, you might be in this period where you are infectious, but yet you haven't developed symptoms. And now you're spreading the virus, okay, unintentionally, but you're still spreading the virus. So that's why it's so important that if you are labeled as one of these high risk exposures, that quarantine means that you are home. You are reducing your contact with other people, because anytime during that period, you could be infectious. And so when you're on quarantine, absolutely incredibly important that you're not out engaging with the community, whether that be going to school events, sporting events, church, whatever it might be. That means you're home and you're really, really limiting your social contacts and family contacts as much as you can, to really minimize that spread of the virus, because you can get spread before symptoms start. And that's the whole point of quarantine. So it's really important that we do that. And some people are getting tested within their quarantine period, as driven by the Utah Department of Health, which is great. And that helps with contact tracings and the like. But if you have a close contact and you're on quarantine and you get tested at day 3, that's great that you've got a negative test. It doesn't mean that you're not going to turn positive at day 5, 6, or 7. And so even if you have a negative test, you still have to quarantine for the full duration. Now, there's work ongoing at multiple different levels, national levels, to say, can you test out of quarantine? If you have a test at day 7, could that potentially get you out of quarantine? That's work that's forthcoming, and certainly is not standard of practice. And standard of practice is that you quarantine for the full 14 days.
That's a really interesting point about even if you get that negative test at day 3, that you stay through that 14-day period, because like you said, you might not actually test positive until day 5 or 6, right. Which is why I think we suggest waiting until day 5, 6, 7 to actually get tested, because then it gives you that chance to get the symptoms. Is that correct?
Yeah, it would definitely be a higher likelihood of having a positive test if you wait to day 5 to 7. But even if your test is negative at day 5 to 7, you still have to quarantine the full 14 days.
I want to talk about a report the CDC released on Monday. It was about airborne particles and the fact that they think it could spread beyond the normal 6 feet that we've kind of ingrained in our brain, but it's not the main way that COVID-19 is spreading. Do we need to be handling social distancing differently at all with this new information?
Yeah, so the CDC is talking about airborne transmission versus droplet transmission. Airborne transmission means that the virus is coming out on very, very small particles and can travel potentially long distance. Droplets are the big kind of wet droplets that come out of your mouth and fall due to gravity and don't go anywhere past 6 feet. And so we certainly have known that the main transmission is through droplets, meaning that they're coming out of your mouth, big droplet particles, they're falling. And so that's where we come to the 6 feet mark, is that's the main method of transmission, is through droplet transmission. That's where we get 6 feet. But there's certainly been examples of airborne transmission, meaning that you get it infected if you're greater than 6 feet away. And those are really special circumstances, but they certainly occur. And so we've seen examples of a choir practice, for example, where people are singing, and we've seen mass infection through choir practices, through airborne transmission. We've seen some some examples in restaurants as well. It really is in areas that are in closed spaces, so that don't really limit or don't really, augment ventilation. Closed spaces and doing a lot of vocalization. And so whether it be singing or yelling, shouting, coughing, those are all times where you potentially can have airborne transmission. And so when you think about social distancing, that's the whole reason why being outside helps a ton, right? Because you've got this increased ventilation. So even if somebody is singing, it's being dispersed in the environment. And so your chance of getting infection is much less. And I think it's a really important point as we move into the fall and winter season, as people are going into the house. Holidays are coming up. People are jovial, they're yelling, they're having a good time. And that is a great time for potential airborne transmission in the right settings. And so yes, it occurs. It's not the predominant way that it occurs, but in certain circumstances, you certainly can have airborne transmission.
It'll be interesting to see, like you said, as the holidays start to approach, kind of what happens with the case counts. If we had our highest case count today, it concerns me that we haven't even really gotten to the holidays yet. We haven't gotten to Thanksgiving, and people have lots of Halloween parties, which is in a couple of weeks. Any recommendations for now on what you suggest for these holiday type events? Let's maybe just focus on Halloween. Do you have suggestions on how people can kind of approach that?
Yeah, I mean, just to back up, I'm very concerned the fact that we have 1,500 cases, the highest amount in Utah that we've ever had. And it's like 70 degrees outside and people are outside. And so, this is the time where we should have the lowest number of cases, right? We can be outside, we can enjoy people's companies. And so ideally, this is the time where we should have driven this number down incredibly low. With the anticipation of a spike in October, November, December. And that's the exact opposite of what's happened. So super concerned. Yeah, Halloween's coming up. A couple of really just kind of thoughtful kind of tips. Obviously, stay outside. Hopefully we'll have some nice weather, but incredibly, incredibly important. Just stay outside. Do not have indoor Halloween parties. This especially goes for college and young adults, where Halloween is, I remember my Halloween adventures when I was back in college and young adults, they were a lot of fun. But, really shouldn't happen in the traditional manner anymore. You got to stay outside. And then for trick-or-treaters, limit your group size. And then, as somebody who lives in a community that has a lot of trick-or-treaters, we're more likely going to kind of set a bowl of candy out and, greet people from the porch and not be handing out individual, candy to people, just because that's going to limit the amount of contact that we have with them. And we'll be able to stay 6 feet away and still be engaged in our community and our neighborhood. And anything you can do to limit the amount of what we call fomites, or things that can transmit germs from hands to hands, is going to be really important. And then wear a mask. Incorporate it into your Halloween costume. I'm sure we'll see some incredible creative things this Halloween of superheroes with masks and all the like. And, I know if we're going to go to our, surrounding neighbors, we're going to wear masks. I'm going to try to convince my 2-year-old to wear a mask. And we'll probably put a mask on our 6-month-old just because he'll look cute. I mean, honestly.
Yeah, it'll be interesting to see how people incorporate that. And I think the no holiday parties inside is a huge important thing. I mean, I was in college once too. I understand how fun they were, but
Yeah.
yes, if you're gonna have them outside. We talked about a heat lamp last time. If you can get a heat lamp before the end of the month, now is probably a great time to invest in that. So we'll see what happens. We're going to go back to the flu really quick. We got a question on Facebook, and I don't know if you know the answer to this quite yet, but someone asked if it's possible to get tested for the flu and COVID-19 with a single swab. Do we have that developed yet?
Yeah, really good question. So, in our drive-through sites and our urgent cares, we're now using a saliva-based method for detecting COVID-19. Unfortunately, we cannot run an influenza equivalent test or a PCR on saliva. That just hasn't been validated yet. We aren't testing for influenza in our drive-through sites either. It's just COVID-19. There are new tests coming out, and again, it's limited capacity. We're working with the distributor to see how much we're going to get, but there are a couple tests that can test for both COVID-19 and influenza at the same time. Most of those tests are limited to our urgent care clinics, and we still don't know whether or not we're going to have access to a lot of those. We're certainly going to need them. So in many instances, and it's a great question from the person who's listening, is that you may need to get a saliva test for COVID and then not one of those bad, retropharyngeal tests, but a standard nasal test for influenza. And so in many cases, you will have to have two tests. We hope that we have the supply in our urgent cares to do the all-in-one test.
That would be great. That would probably make life easier, especially for our caregivers, simplifying that process. Sounds like it would be super helpful. Last thing I want to talk about is vaccines and therapeutics, specifically about the drug that President Trump received when he was in the hospital, and how this drug works. I know that we talked about this drug before in previous Facebook Lives and how it's been taken into consideration with research. Will you kind of explain what this drug is, what we know about it, or what the scientific community knows about it, and if it's going to be effective for other people?
Yeah, so there's been a lot of news about this. So there's two drugs that are out there. One's made by Regeneron and one's made by Eli Lilly. Both of these are what's called monoclonal antibodies. The Regeneron products has two different monoclonal antibodies. So it's a kind of a monoclonal antibody cocktail. The Eli Lilly has one monoclonal antibody. The antibody detects the receptor binding domain on the spike protein. So that's a mouthful. But on the virus, there's proteins on the outside. Those proteins are essentially what connect to our cells and allow the entry of the virus to go into our cell. The antibody attaches itself to that protein and doesn't allow the virus entry into our cell. So that's what a monoclonal antibody is for this virus. And the thought is that when people get infected, if you give them a high dose of this monoclonal antibody, it will bind to all those viruses and not allow their entrance into the cell, and hopefully prevent severe disease or hospitalizations or death. And so this is the same idea of using convalescent plasma. So initially we were talking about convalescent plasma. I got emergency use authorization. The whole point of using convalescent plasma is to give people these antibodies, right? And so what this drug, or these two different drugs, are doing is essentially taking the really active part of convalescent plasma and cloning it and making it into a drug. And so it's essentially the equivalent of convalescent plasma, but likely higher concentrations and more specific to that particular part of the virus. I want to be really clear. We do not have data on the effectiveness of these drugs. Okay, so President Trump said this was a cure. This made him feel 100% better. That may be the case. There's absolutely no data to support the effectiveness yet of these monoclonal antibodies. These are still under research protocols only. There's a number of research trials, some here within Intermountain, that is looking at the use of these monoclonal antibodies in hospitalized patients. And the NIH is also setting up a big trial of using these drugs in patients that get diagnosed as an outpatient but don't require hospitalization to see if they prevent hospitalization. And so these stand to be a very good drug, and we are optimistic that they will work, but we don't have data to show that they're effective. And more to come on that. I'm hoping in the next kind of weeks to months, we'll start seeing some preliminary data to get a better idea of how well these work. And then we'll just have to wait and see in terms of what the production of the monoclonal antibodies are and what's the cost of these drugs. Typically monoclonal antibodies, whether it be an infectious disease related product or a rheumatologic product, are very, very expensive. And we'll have to see what the drug makers price these and how much supply we have of them. So there's going to be a lot of flurry of activity surrounding this in the next kind of weeks and months to come.
Last thing for you on the vaccine. I know that before we started the Facebook Live, you were talking to me about the FDA and this 60 days of data that they're going to be asking for with a vaccine. Can you explain what that means for people? I know that Vice President Pence last night talked about the vaccine being available in the next couple of weeks, but I want to talk about that 60-day piece that the FDA mentioned.
Yeah, the FDA came out with some language for pharmaceutical companies in terms of when they would consider an application for an emergency use authorization for vaccines against COVID-19. And what they said is that they're going to require that after the last dose of the vaccine, they're going to need to require a meeting of at least 60 days of follow-up. Okay, so when you look at the vaccines that are in the US under studies right now, the Pfizer vaccine, the Moderna vaccine, the AstraZeneca vaccine that's been put on hold, and then the J&J vaccine, all of those vaccines except the Johnson & Johnson vaccine require a 2-dose strategy. And so that means that after the second dose, we need at least 60 days of follow-up on average for everybody in the trial before the FDA would actually consider an application for this. The Johnson & Johnson trial only has a 1-dose regimen, but J&J just started enrolling 2 weeks ago. And so they were kind of fourth in line for this trial. And so when you look at where these drug companies are in their development, Moderna and Pfizer are farthest along, but they just essentially are finishing enrolling, just recently. So you really have to tack on 60 days from then to get a median duration of 60 days for the analysis. And so that puts us out mid to late November. I think there was some pushback from the White House early on when that came out. That seemed to have lessened. And so it really looks, from a timetable set by the FDA of when they would actually evaluate this, it would be, mid to late November at the earliest. And there's a big and, is that in each placebo arm, there needs to be at least 5 cases of severe COVID-19 pneumonia. And so you just have to have enough cases in the placebo arm to make any kind of adequate comparison. If there was only 2 cases in the placebo arm and 1 case in the vaccine arm, that's not enough to power an analysis to actually show a benefit. And so you're going to need a significant number of cases in that. And I think it's really important too that when we think about this vaccine, compare and contrast 2 vaccines, right? We have a measles vaccine, which is 95% effective, and over 90% of the population have taken the vaccine. And that's why we don't see measles, versus an influenza vaccine, which is about 50% effective, and only about 40% of the population get the flu vaccine. And so where is coronavirus vaccine going to fit between those? It's most likely going to be more like flu than measles. It's likely not going to be 100% effective. And we know based on polling that people are skeptical and not likely to get the vaccine. And so what that means is that we're a long ways off from herd immunity. Like, that's not going to happen if only 50% of the people are getting the vaccine and the vaccine isn't 100% effective. And so what is the long-term implication of that? Well, the long-term implication of that is that masks are going to be a part of our daily lives for a good bit, as is, social distancing and large gathering limitations. And so it's something for us to really kind of keep in mind that vaccines they're going to be great. It's going to be an incredible tool in our, toolbox in terms of how to fight this. But it's not going to be the magic bullet. And it's going to potentially just be another tool along with therapeutics and along with public health measures that we use to, get us out of this epidemic.
That's some really great information about the vaccine, and hopefully lets people kind of see what's going on with that. Eddie, is there anything else you wanted to mention to us about this past week and any concerns with what's been going on?
Yeah, I mean, I think, just disheartened in the fact that we have the most cases today. This rise is not going anywhere. Our hospitals are full, and we don't see things changing. We don't see things changing at the government level, at the local level. We need to do something and do something different if we want a different result. And so we really need to call on each one of us as individuals and part of a community to say, how can we impact this epidemic for the state of Utah? Utah can come together. We've seen it before. We got to do it again. And we really have to change this current trajectory and really kind of decrease our cases and decrease our hospitalizations. People are dying unnecessarily, and we need to change that.
I'm going to ask you one more question. Someone is just typing it out for me really fast. While they're doing that, I think it is important. You mentioned calling on like everyone locally and making sure that you're actually making the effort. And I think that is the most important part. You can't rely on your neighbors or whatever to do the right things potentially. So you have to do it yourselves and take that initiative. So this person's question has to do with the flu, and we'll just talk about it really quick. They wanted to know, does the coming in a flu season raise your concern levels that hospitals are going to have enough resources to handle both COVID patients and flu patients? We didn't touch on this specifically, so this is a great question.
Oh yeah, huge concern. I can say we cannot handle a severe flu pandemic at the same time as a COVID pandemic. Just can't. We don't have the hospital. We don't have the healthcare workers. We don't have the capacity in our hospitals. If that were to happen, you're going to see makeshift hospitals being set up in our arenas, being staffed by doctors and nurses that aren't trained to take care of patients with COVID-19. That absolutely is, a prediction I'd stand behind. If we have a severe flu pandemic or flu year, it's going to be disastrous.
And on that note, I will give you the information that you guys need in order to find out about those flu clinics. Again, that website is intermountainhealthcare.org/flu. There's an entire list of all the different curbside flu clinics that we are offering. And also, if you ever have any questions about COVID-19, you can call our COVID-19 hotline at 844 442-5224. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Eddie, as always, thank you for joining us, and we'll chat with you next week.